So I'm guessing this debate will continue. Let me invite Dr. Timothy Mixon, endowed professor of cardiovascular medicine from Texas A&M. And Dr. Mixon is going to talk about 5 most important trials of 2015 in exactly 10 minutes. Thank you.
All right, thank you. Yeah, they didn't tell me I only had 10 minutes when they actually asked me to do the case, so we better jump right in. Fasten your seatbelts. So I've picked out various trials that I think touch upon really a wide spectrum of interventional cardiology, which is what I predominantly do, and show you some of the major articles and developments that we've had in 2015. So the first one has to do with STEMI interventions, and we mentioned this a little bit last night. The backdrop here is that a lot of our patients who present with STEMI have more than the culprit. They have multivessel coronary disease. And up till now, our guidelines have been pretty firm, including the 2013 guidelines, which are our last full guidelines, that would actually assign a class 3 indication to doing anything other than the culprit vessel. Now, that paradigm was challenged a couple of years ago by the PRAMI trial, which was the first trial out of the UK that began to question whether we could safely do it. And so we actually have 2 different trials that were published in 2015, which can add to this. These were referenced last night as well. The first was the culprit trial, and I've given you a lot of detail on the slide. I'm not going to read through the entire thing, but basically it's really a small to moderate sized trial. You can see there are only about 300 patients who presented with STEMI, but also had additional coronary stenoses other than the culprit. And then they were randomized to either complete revascularization based upon the severity of the lesions or to culprit-only PCI as we would normally do. And you can see there in the chart on the left the outcome, which is based upon a composite endpoint, multiple things, not only death, MI, heart failure, and quote, softer endpoints such as repeat revascularization. And again, they showed a very similar result that what we had seen in the PRAMI trial, which was about a 50% reduction, again, in these composite endpoints. Again, it's an underpowered trial. How do we interpret this? I think one thing that is interesting is that when you look at each of the individual endpoints, while none of them are statistically significant, they at least are all directionally consistent. And I think that does make us wonder whether there is something there. The second trial that was also published this year, similar type of trial, similar size trial, a little bit bigger, 600 patients, was the Dynamic 3 pre-multi trial. Again, a trial looking at STEMI patients who had more than a single lesion, and they actually employed an FFR-guided strategy to look for hemodynamically significant stenoses, and then they were randomized to treat all of those or some of those. Of course, one of the underlying questions that we still need to answer, and these trials differ slightly, would be even if we do choose to do multivessel PCI, what is the best timing? Is it at the initial procedure, or would it be later in the hospitalization, a week later, 2 weeks later, sometime early, or not? Again, similar types of outcomes, not quite a 50% reduction in the primary endpoint, which is, again, a composite endpoint of not only death, MI, and revascularization. So I think on the basis of these now 3 trials, the guidelines were revised. There was just a very short update that was published in October of this year, really focusing on just 2 issues, one of which was this issue. And they did feel that given the data that we currently have, while it's not definitive data, they did feel that removing it from a class 3 harm to a class 2B, that is, we can do it selectively under certain circumstances, seems to be reasonable. So moving on to another area, I wanted to talk a little bit about structural heart disease. As you know, there's been a big revolution in percutaneous options available, not only for aortic valve disease in the form of TAVR, but now starting to be in mitral valvular disease. And so I want this to be maybe a little bit provocative more than anything else. It might be an interesting selection, the NOTION trial. Again, kind of a small trial, 281 patients. We know that TAVR is pretty well established in the inoperable patients or those who are high risk. And now the question really becomes, what's the space for TAVR, maybe in intermediate risk patients or even in low risk patients? So the NOTION trial was kind of an all-comers trial out of Scandinavia. Again, not a real big trial, about 300 patients, but it was actually predominantly low-risk patients. So it's kind of our first look at how TAVR might compare to surgical AVR in low-risk patients. And so you can see, again, composite primary endpoint, death, MI, or stroke on that top line, not statistically reduced with TAVR, but a trend toward a reduction there. If you look at all-cause death on the next line, again, not statistically significant. It's underpowered for that, but we certainly don't see a signal for harm with TAVR, and if anything, we see a trend toward a reduction. We see the observed versus expected ratio. We can pretty well predict the mortality outcome we're going to get with surgery based upon the STS database. So that observed versus expected ratio, we see with TAVR, we got about a 30% reduction in what we really expected, whereas surgery, we got pretty much what we expected or even just a touch higher than that. Reduction in strokes with TAVR. So again, I think it's a very interesting, tantalizing piece of evidence. Certainly, we're not going to change practice yet, but it may be foreshadowing of what's to come in the future. And then the other one that was presented, not yet published, this was at ACC this last year. This is 30-day data on the intermediate risk patients who were studied with TAVR. And again, this is not a randomized controlled trial. This is actually a historical comparison trial. But again, intermediate risk patients who underwent TAVR. And what we found here was extremely low risk of mortality, 1.1%. That's about 80% less than we would have predicted with an STS average of 5.3. Stroke rates, disabling stroke rates, very, very low, certainly seem to be well in line, if not below, what we would expect with surgical AVR. So again, we expect in Chicago at ACC this year to see the one-year results of this, and then based upon that, there will perhaps be applications for expansion of the indication for TAVR. So the bottom line, I think, in the aortic valve area is that we certainly have strong signals. Short-term outcomes in TAVRs appear to be at least equal, if not even a little bit better than surgical outcomes in intermediate and low-risk patients. Stay tuned for more to come. We certainly need more data before we would be doing that on a regular basis. The next, I think, big area in interventional cardiology is stent design. And of course, this is something that we're continually working on to try to improve the stents, and we really saw that come to fruition, at least in the publications this year. And of course, the biggest one was the Absorb 3 trial, and this is the first bioresorbable stent. So the entire stent is something that can be broken down by the body and with nothing left behind. So the Absorb 3 actually has a rather daunting task, and that daunting task is comparing itself to what are some very, very excellent stents that we currently have available. So our current generation drug-eluting stents have extremely low rates of not only restenosis, extremely low rates of stent thrombosis. So trying to at least meet that, much less improve upon that, is a very high bar, and I think we have to bear that in mind. Of course, the disadvantage is that with current drug-eluting stents, we're leaving a stent behind forever, and there may or may not be disadvantages to that. There certainly are some theoretical disadvantages to that, and therefore some theoretical advantages of a bioabsorbable stent. In other words, you allow early scaffolding of the vessel, but over time that scaffolding breaks down, and there's some idea that maybe if we restore normal vasomotion to a vessel, that might be advantageous long term. This is a stent that's available in Europe, but the Absorb 3 trial that I present here is what will serve as the pivotal U.S. trial as the company seeks to have approval for that. On the right-hand side, you see the comparison, the Absorb stents in blue, the current sort of standard, current generation DES, such as the Xience V, is represented in red. And you see there across the board, if anything, the blue is just a touch higher, so it's actually a touch inferior. But statistically, these numbers are all within non-inferiority. So it was shown to be non-inferior to the current generation drug-eluting stents. They did testing for superiority. Of course, that was not met. And so it remains to be seen how that will be viewed. I should add to that perhaps the one disadvantage that we have seen, and there's been quite a few publications in the last month or two, is about concerns of stent thrombosis with the bioabsorbable scaffold, and so that'll be something that we still need to work out. The other stent that was published and has been approved, again, more of an iteration than a bioresorbable stent, same drug, but a bioresorbable polymer. And again, some theoretical benefits to the polymer completely going away, maybe less inflammation in the vessel, maybe better healing long term. That remains to be proven clinically. You can see when it was compared to, again, current generation best stent, like the Promus element, there was actually no difference. So this stent was approved. I think we're still trying to find the niche for this stent in terms of what we think are theoretical advantages, but those have not yet been proven clinically. Kind of apropos to the debate we had earlier about the duration of antiplatelet therapy, some have theorized that perhaps with the biodegradable polymer we can get away with shorter DAPT, but that has not yet been proven. So to put this in perspective, the bioabsorbable stent, it is statistically non-inferior, but there's certainly no signals for superiority right now. Now, a lot of why we're excited about it is the hope and the promise of what it might lead to. It might lead to an uncaging of the vessel, and that might lead to less angina. It might lead to other positive things. But again, those are not proven at this point. And when you compare one-year results, they appear to be nothing better than equal, and maybe just barely equal. They are more technically rigorous to implant, probably going to be more costly, although we don't know that for sure. And as I said, the thicker struts have been associated with higher subacute stent thrombosis rates, and that's been highlighted of late. And then lastly, I want to touch upon something that I know is near and dear to a lot of you guys here, and that is the area of CTOs. CTOs are really probably the last frontier in PCI in terms of what keeps us from being able to successfully treat patients and treat as many patients. While we know that a lot of patients, maybe up to a third of angiograms show CTOs, they actually account for a very minority of the procedures. I've kind of quoted 10%, although in the paper I'm going to show you it was even less than 10%. A lot of the publications are dominated by what I'll call CTO experts, and that's both good and bad. Those are the leaders in our field, and they're pushing us forward, but they don't always give us a real-world look at what's going on here. And so actually both of our directors here, Manos and Subhash, were the lead authors in this paper, which was derived from the NCDR database and looked at CTOs over a 5-year period. And basically what they described was that, number one, I thought was surprising that the number, I believe, was 3%. Only 3% of PCI procedures were CTO procedures. And so while we know that there's a lot of CTOs out there, as a whole, as a community, we're not tackling very many of those CTOs. Now, some of those are going to surgery, obviously, but that probably continues to be a detriment or something that keeps us from doing PCI. On the right-hand side, you see the success rate, and it is gratifying to see that the success rate is trending upward. We're still seeing across the country around 60% success rates. Obviously, again, very high volume centers are seeing 80 and 90% success rates. And I think one of the things that came out of the paper, which we sort of suspected, but again, they crystallized for us, was the relationship between procedural volume and not only success, but also MACE outcomes, and that is those operators that are really devoted to this and are high volume operators see greater success and enjoy lower MACE events. There's been some other articles that have been published in terms of CTOs. One was the experts, a CTO expert, which again was published by CTO experts. I think that's wonderful. They found an astounding 96% success rates and really showed very low TLR rates and adverse event rates. So again, it kind of shows what we can shoot for. And then the last one I'll mention is, again, not published yet, but was presented at TCT this last year, Explore CTO. One of the areas where we have felt like CTOs would probably be useful would be in post-STEMI patients. We know that STEMI patients who also have a CTO do worse than those who do not. This is a small trial, probably an underpowered trial, took a number of years to complete, but disappointingly, they didn't show any benefit with additional CTO PCI after STEMI using surrogate endpoints such as LVEF and LV size. I think there's a lot we could say about that trial in terms of the endpoints being underpowered, but again, a little bit disappointing there. Some honorable mentions, probably should have mentioned the PCSK9 inhibitors, but hey, I'm an interventional cardiologist, so it didn't sound quite so sexy to me, but we'll mention those there, and I want to thank you for your attention.